Thank you, Jacob, for that wonderful presentation. So right now we're going into our last presenter, Michael Mikulski. Michael is a licensed marriage and family therapist, and he is the director of the MFT training at Pacific Clinics at the Foothill site, a clinical supervisor, and is in private practice at the Feeling Good Institute. In 2001, Michael began his career in community mental health as an outreach coordinator at Angel's Flight, which is a shelter for runaway children. Angel's Flight serves high-risk youth in the Los Angeles and East Los Angeles area. He is a graduate of Fuller Theological Seminary and provided therapeutic services to clients at the Asian American Christian Counseling Center from 2003 to 2020. Michael has a passion for helping clients achieve health and well-being and for staff to achieve their fullest potential. Please welcome Michael as he presents an overview of treatment considerations for treating people with bipolar disorder, including differential diagnosis, cultural considerations, tools, and interventions to engage patients and family members. Welcome, Michael, to our conference, and thank you.
Thank you. Okay, hello. I'm Michael Mikulski, licensed marriage and family therapist. I'm very excited to share with you this training on bipolar disorder. This is an overview. It doesn't cover everything about bipolar disorder, but there are some important tools I've learned along the way, and perhaps you use some of these, but I hope this will be helpful for you. In the beginning, when I graduated with my MFT degree, the truth is I didn't know what to do when I came across bipolar disorder. One of my earliest cases after I graduated was an 8-year-old girl. I was called to work with her. She was very sad in class. And her grades were going down a little bit, but she was doing all right. And I met with her, and my mental status exam saw that she seemed to be doing okay, but was a little down. And in talking with her, I learned that her mother had some problems. And in fact, her mother had bipolar disorder, but the family didn't know what to do about it. In this case, their mother would get these large pots, fill them with water and boil them all night long, and put household items into the boiling pots of water. And I figured this was bipolar disorder, but I still didn't know what to do for the family other than refer her to a psychiatrist. And they didn't have insurance, so they used to go to Mexico to go to doctors, but also curanderos, and try to find cures. And sometimes those worked. And that's how they were kind of dealing with bipolar disorder for years. Another case, my first year as an MFT was with a 12-year-old male of mixed race. And they lived in apartment buildings, and his mother was known as the lady who runs around naked. Obviously with a major manic episode. So I'm describing some manic episodes here. And it's hard for most people to understand mania until you come face to face with it. And I'm hoping to convey what that's really like in this first part of this presentation. My sister-in-law, there she is, Vicky, has bipolar disorder. And her first episode was in the year 2000. And you could see here a very busy street in Taiwan. And her first episode, she was about 30 years old. And she began kissing all the people in the restaurant she was managing and telling them she loved them, which is very unusual for Vicky, who's very shy. And then she ran out into a very busy street without any regard to her own safety. And it alarmed people so much that several men held her down for her own safety until the ambulance came. That was her first episode at the age of 30. She came to visit us in America in Pasadena in 2004. And I'd like to begin this first part of this presentation with this story because this woke me up. Even though I had those other clients who had bipolar disorder, I simply referred them to the psychiatrist, and I didn't know what I could do for the family. Well, when Vicky was staying with us, she started off doing well. She was taking English classes. She was going to stay with us for 6 months. And but then, and she showed us this big bag of pills, lithium pills, when she started to unpack her things. And my first mistake was thinking that's totally her business, whether she takes her medicine or not. And it's true, but there are some things family can do, which we're going to get into in a little bit. Well, Vicky started to have warning signs that I did not understand. She started to speak out in Bible study with my wife. It was all in Mandarin, Chinese, and that's unusual for her. But I didn't understand this was a warning sign of an impending manic episode. The next week, she started to shout really weird things in the class, and I still didn't pick it up. I was just wondering, why is she shouting really weird things in Bible study? And then my wife tells me that she's staying up all night, night after night, wandering around our tiny little apartment in Pasadena. And I was wondering, well, why is she staying up all night? I thought maybe it was jet lag. But she wasn't sleeping in the day either. And she gave me permission to share this story. At one point, I was watching TV and she came over and kissed me on the lips. And I turned around to my wife and said, well, what's going on? And my wife looked at me in horror and said, my sister-in-law thinks she's my wife, and my wife is the sister-in-law. Then Vicky went to the front door and opened it and closed it and opened it and closed it in this crazed look on her face. And at that point, I realized that there was something wrong. Right? I had never seen a manic episode up front. And it's different from normal mood swings. And this is what people get very confused when they're diagnosing bipolar disorder. It is really unusual and can be life-threatening. In this case, what I did, it's a long story, but we ended up taking her to Huntington Memorial Hospital, where she stayed for 2 weeks. And she didn't recognize my wife for a full week on medication. And she finally started to talk again. And we put her on the first plane back to Taiwan to get back to her psychiatrist. And this was the trigger for me to start learning about bipolar disorder in detail. What is it, and what can we do as clinicians? And in my study, I learned to make it systemic, to have an outline or a list of what you want to accomplish when you're working with a family or the client who has bipolar disorder, and you want a really good assessment and history. And it's helpful if you could get information from the family, because Vicky doesn't remember any of her manic episodes. But she's treatment compliant. She's taking her medication. She's read some books on bipolar disorder, and she learned about it. So we want an excellent assessment, looking at substance abuse. Vicky doesn't take drugs or alcohol. We want to look at suicide and of course, refer for a full physical to see if anything else is going on. The next thing we want to do, and I'm going to kind of pull these out a little bit in this presentation, is we want to do a great psychoeducation of bipolar disorder for the client and significant others. We really want a clear idea of what it is and what it's not. We want to do a great job with stress management. And a really important part is relapse prevention and identifying warning signs, which we're going to go into detail. The last speaker talked about warning signs for suicidal risk. There are warning signs for bipolar disorder, in particular for major depression and manic episodes. We also have a role as therapists in building supports for the people, building their activities and a balance in life. And we want to use a client-centered approach. We don't want to run the client's life for them. We want them to understand their bipolar disorder and sort of guide us in organizing their life so that we have some really great things in place. I wish I could see you all so I can get in the moment questions, but I'll just keep going here. One of the things that I do is I use a whiteboard, and I've also done this through telehealth using a piece of paper. And this is assessment and psychoeducation at the same time. The reason I use a whiteboard or a piece of paper to do this is because there's often lots of problems happening and sometimes lots of chaos. And I want to focus the client and the family on this part. And what I do is I draw a line across the middle of the page, like you could see here. And that's, I call our neutral mood over time. Of course, we don't have neutral moods, but I just kind of mention that. And then I draw a squiggly line up above the neutral mood and down below. And I explain to the client and the families that this is normal. We all have normal positive moods and we all have normal negative moods. There's a certain normal range that we all go through. All things being equal, we usually have a little bit above the neutral line. We have enough energy to get up and shower, get dressed, eat breakfast, talk to our family, maybe even hear the birds singing outside, and get on with our day. That would be sort of our normal mood. But we have sad days, we have disappointments, we have difficulty pulling up the PowerPoint, for this presentation. That was a little stressful. So that would be a negative mood, but popped out of it, right? So we go up and down, and that's kind of normal. That's not bipolar disorder. Everybody has, if you will, some mood swings in the normal range. What I do is I draw a line really far down, and I talk about depression. And I ask the client or family member, have you ever felt depressed, or has your family member felt depressed, and what was that like? And I use their words and I write it down. They might say, well, I have unclear thinking and nothing makes sense, and I just stare out the window. And I write their words down, and I'm going to apply that, if it fits, to the DSM-5. Usually they'll also say something like, I can't get out of bed. I have no motivation to do things. I'm very depressed. Or I think of suicide or death. So I write those down so that I can get an understanding of, have they had a depressive episode or not in their life? And I use their words. And what I'm doing here is I'm either confirming or disproving that they have bipolar disorder, depending on what they tell me. So this is the psychoeducation and assessment phase. And I make it visible. As therapists, we're not really taught to make things visible, but sometimes I find it really important to draw things out. It focuses the attention. I can gather some great information. So if you're a little shy of using a whiteboard or a diagram, you might want to give it a try. I find this tool really helpful. And then conversely, I draw a line all the way to the top, and that's mania, because bipolar is two poles, right? A manic episode and a depressive episode. Now, the manic episode, I circled it in red here because this is the main criteria for a diagnosis of bipolar disorder. They have to have met criteria for a manic episode. Again, I want to get the client's words. What I explained is sometimes in life, we all feel pretty good. It seems like the stars have all aligned for us. We have this sort of energy and vitality, not due to drugs or caffeine or anything. And then I ask people, how long does that stay in your mind? How long do you feel really good for? And it's usually just a few hours, maybe a day if you're lucky, when you feel sort of this extra good. And then we go down to baseline. But mania, they keep going up. The energy is just super, super high. Everything seems so easy. They stay up night after night and all through the day. This person, Kay Jamison, in her book Unquiet Mind, when she had a manic episode, she read everything that wasn't nailed down. The world was filled with pleasure and promise. She felt really great. Her mind seemed clear and fabulously focused in other number of other things. So sometimes we confuse bipolar disorder with the mood swings of teenagers or even adults. And we have to be really clear, is this a manic episode? And one of the main cues is that they're not sleeping or barely sleeping, and they have a ton of energy the next day. If most of us only sleep 3 hours at night, we're going to feel it the next day. But person with a manic episode they're going to be flying. They're not having a problem. Here's an example, a picture I took of actually doing this with a family, and I've done this in Chinese, having somebody translate for me, and also Spanish. And we looked at their depressive episodes and what that was like, and their manic episodes. This really paints a picture so that you can also differentiate, is this bipolar disorder or is there something else? I did this once with a person who was diagnosed with bipolar disorder, and she didn't mention any depressive or manic episodes. It was about anxiety, but she had been misdiagnosed, quite possibly. Here are the common misdiagnoses for bipolar disorder. When a person has major depression and we fail to gather a complete history. Substance-induced mood disorder, right? So we always have to consider if they're active on medications, on drugs or medications. Borderline personality disorder. What's the difference? We're going to look at that in a little detail here. Schizoaffective disorder can be bipolar type, but it also has schizophrenia, the symptoms associated with schizophrenia. Then ADHD can look very much like bipolar disorder, especially bipolar 2. So getting a really good history and knowing your bipolar disorder and what it is super helpful. Here's sort of a comparison page on bipolar disorder and borderline personality disorder. For bipolar, their mood swings are usually measured in days, like 5 days or weeks or even months. And then borderline is usually measured in hours, right? Maybe days, but it's usually very much within the day. Bipolar disorder, their mood swings are frequently not triggered by life events. They can be triggered by some stresses, but the difference is with person with some features of borderline personality disorder, the mood swings are typically triggered by life events. Feeling very sensitive about slights or perceived abandonment. For bipolar, there's a family history of bipolar depression and major depression. For people with personality disorder, the family history is typically drug abuse, impulsivity, and depression. And then the manic, hypomanic episodes are characterized by classic symptoms of bipolar disorder. Whereas in borderline, mood swings are rarely characterized by decreased sleep, increased energy, and elation or grandiosity. So that's a good one to keep in mind. Another thing you can do, and I won't go into this very detail, but look at the DSM and compare whatever it is you might be comparing. In this case, for the borderline person with borderline, a pattern of unstable, intense interpersonal relationships is the key feature. For bipolar disorder, it might look like being more talkative. Another one, let's look at the third one, affective instability due to reactivity of mood for someone with borderline. And bipolar is more of a great increase of self-esteem and grandiosity. this is different when you get to learn bipolar disorder in detail. And then what's similar is that they can seem kind of similar in these ways, and then different. One has to do with a lot of energy, and the other is perceived breaches in relationship, just to put it in a nutshell there. I really wish I had longer in this talk, but that'll give you an idea of how to do a good differential diagnosis. I also use the whiteboard to draw this image out. Bipolar disorder is episodic, so it has episodes. There's periods of stability. Whether the person's on medication or not, they could function pretty normally. And what you want to do is pay attention to warning signs. And what are that person's warning signs for an impending manic episode? And with Vicky's case, we've been able to catch the warning signs early and intervene so that, as you can see, she can come back up to stability quickly. So I think I have time for a story or two here. I would be listening. I would hear my wife talking to her sister on the phone. Her sister's in Taiwan, and they're talking in Chinese, and I don't understand Mandarin Chinese or Taiwanese, but they would be talking, and I would notice a change in my wife's tone. And we would talk, and my wife would tell me that Vicky is talking weird. So when they say talking weird, that's sort of identifying possible warning signs, because it's a change from her behavior. And she would be staying up later and later and not going to sleep. So how we intervened, even though we were here in the United States, is we would ask her to go see her psychiatrist right away. And at first, she would delay this, but she got used to the idea of going right away, and the psychiatrist would adjust the medication, and we could avoid a full-blown manic episode. And we've actually avoided quite a few of those. What you're going to look for is sudden changes in their behavior. Their body language can become very stiff. They can start to try to accomplish much more than they would normally accomplish. Obviously, talking really fast is a big indicator. They show really heightened energy and a decreased need for any kind of sleep. And then cognitive, that they might actually think that they are really married to somebody they're not, or that they're close friends with a movie star or something like that when they're in their manic episode. And usually they feel very powerful and invincible. And we want to catch these things early so we can intervene. Once they're in a manic episode, it's very difficult, and we do want to bring them to the doctor, or they may need hospitalization. So one way I think about the warning signs is a personal signature. We all have our own signature. And I think of a warning signs as a person's own signature. So when I'm working with a client who has bipolar disorder, and we've done the diagram and they get it, they're like, yes, what can I do? We do a history and we look at what happened before their manic episode. What were the changes? And we identify a list. For example, here's a list of Vicky's warning signs. She's talking weird. She's not sleeping. She won't get out of bed. She has rigid body language. Hard to describe, but not relaxed, right? Something like kind of uptight, sort of. She seems to be in a rush all the time. For her, she's very shy, speaking out in public. That's very unusual for her and in her culture. And she says everything's okay, but she seems a bit off, right? So this is at the beginning of warning signs. We want to pay attention to that. What we want, if possible, is for families to be the eyes and ears for the client as well, because the client might like the sudden boost of energy. I know I would, and might ignore the warning signs. So what we want to do is work with the client and say, if you're beginning to have manic episodes, what do you want the family to do if they're noticing it? What do you want them to say? What do you want them to do? What do you want them not to say and not to do? It's really important that the client have a sense of control over their own life, even when they're beginning to have a manic episode. And that's what I meant by a client-centered treatment plan. Is when they're stable, we can have these conversations and the client could say, yes, when I'm beginning a manic episode, do this and don't do that. And, to help get the person to the doctor or nurse, or to get at least a med-eval or to decrease stress. Families are not prepared. That's a crucial role that we have as clinicians in working with not only the client, but families. Of course, we want to get a release. And we want to hear the families out because sometimes they're burnt out, sometimes they're confused, sometimes they blame themselves, and of course it's not something to blame them. This is an actual article about my family. There's Vicky on the left, my son, her brother, my wife's brother, and then there's my wife with the dog. What happened, and you could see the fire. There was a fire in their apartment building. In this case, what happened was, this is what most likely happened, and that we all kind of think is that Vicky, they stay up late in Taiwan. I don't know if you know the culture, but they're always up very late. She was smoking in a massage chair, watching TV, and she took her medication, which makes her feel very sleepy, and she fell asleep while smoking. And then she went upstairs to bed, and then it caught on fire. And there's a long story, but they escaped onto a roof. It was very dangerous. People across the alley told them not to jump because they would have died, and they escaped. And I immediately knew. I was here in California, and I got a call from a doctor that said your wife and kids are okay, but your wife can't talk to you right now. Your kids are here. And you could see they were 2 and 4. So I got a leave of absence from work for a month so I can go take care of my wife in Taiwan. And I knew when I was flying there that this might cause Vicky to have a manic episode, to relapse. Because stress, although it doesn't cause mania, can trigger a relapse. And sure enough, I noticed in the hospital those rigid body languages and her wanting to do tons of things. And I begged my wife to take her downstairs in that hospital where her psychiatrist happened to be to get an eval, and he did, and he agreed. She was about to have a manic episode, and he adjusted her meds, and she avoided a major manic episode there. So the fallout can be pretty big for families, and they may have had some horrible experiences. We love Vicky; she's great. There's no problems, but families may need your help, right? Talking about things and normalizing experiences. Here's a mini toolkit for mania or hypomania. You don't want to argue with somebody if they're, kind of manic or hypomanic. You want to encourage them to call the doctor. Hopefully you have a plan already agreed upon. You want to look at their sleep. Okay, what is happening in their stress? A number of things to do. I'm looking at the time, so I want to move a little bit here. You want to do a daily care chart. This is actually somebody I know's chart. I'm calling her Carol. She probably wouldn't mind if I used her real name. But you can see that she's charting every day her meds, whether she's taking it or not, her sleep, how many hours, her mood, right? From 0 to 10, maybe 8.5 was pretty good energy. Is she exercising? Her weight, cups of coffee, okay? A number of things that you can just design your own daily care chart. And you can just search it on Google because there's all kinds of mood charts that people can use and fill out. So they could create their own. A really important part of working with someone with bipolar disorder is that they totally understand their own moods and their own stress level and chart it out. Really is very helpful. And it's helpful for the family to get an idea of what is a baseline mood, when does it start to go off kilter, and how do you keep stress, balanced as best as possible. How you speak to the person with bipolar disorder. You don't want to argue or yell at them, of course. I'm very curious, what were your reasons for stopping your medication, right? Non-intrusive, but, reminders. Here's another visual that I use, and I draw a line, and on the left I write denial, and on the right I write overprotection. And I do this non-judgmentally, and I invite the family members to come up and tell me, where are you as far as her bipolar disorder? Are you feeling more denial, like it's not really true, she's faking it, or are we overprotecting? Do you think that just because your family member has bipolar disorder, she can't do anything? I had one family who were taking custody of her children, even though she was an adult, and functioning pretty well because she had bipolar disorder. Well, that people with bipolar disorder, if they understand their illness and they're managing the illness, they could do just about anything. They could work full time and competitively. Vicky has her own condo in Taiwan. She owns and manages a restaurant. She's doing fantastic, and people can do that. And families will do this. They'll come up and they'll mark where they are. And I just talk about it with them. It's normal to feel overprotective. That's a sign of your love. And in fact, it's normal to feel denial. That's a sign of your love too. You want them to not have this difficult illness. I also do sort of and we're getting near the end here, an idea of how to deal with stress and support. And I put some books out and maybe a piece of cardboard on top, and I begin putting things in the middle of the cardboard to demonstrate stress, right? All of us have stress. We're working, we have deadlines, we have to give presentations on bipolar disorder. So we have normal stress. And what do we do when we have stress? So there's a couple of helpful things. We can have a reasonable number of tasks and therefore feel balanced. Sometimes we need to increase the support. So I show that by moving the books toward the center, and the number of tasks they're able to accomplish the same number of tasks because they're feeling support by family and friends. But if they're not able to get the support, they need to remove some tasks, right? So you and I, when we're very stressed, it's helpful to try not to accomplish so much, and then we can still kind of function pretty well. I hope that came across clearly. It's much better in a live demonstration. Bipolar is serious. It's the 6th leading cause of disability worldwide. There's an early onset, and it's chronic in nature. There's Kay Jamison, who wrote a great book. Life expectancy is less than people without severe mental disorder. From 4 to 20 years, they could die up to 20 years earlier, and that's usually from not managing the illness very well. Bipolar does not discriminate. It affects 2 to 4% of people all over the world. Doesn't matter the race or economic situation, but treatment rates are discriminatory. We want to make sure everybody's getting good treatment. And in particular, African Americans have reported significantly high rates of receiving a different diagnosis than bipolar disorder. For some reason, I'm not sure why. but we want to take in people's ethnicity, their culture, their background, and do a really good, clear assessment. And then there's my research content, and that's the end of my presentation.
Hi, thank you so much for that presentation. It was very interesting, and I really like the tools that you provided to us to continue to work with our clients. We have one more question. One question at a time is pretty short. What is the main cause of bipolar disorder? It's like actually a multifaceted question. Are we born with it? Does it happen over time? And what causes it? And can we prevent it?
Okay, well, there's no definitive ruling on what causes bipolar disorder, but there does seem to be evidence for a genetic link, right? So that it's quite possible, part of our genetic background. It's not likely that it's caused by environment, but environmental stress can trigger, right? If a person's vulnerable to bipolar disorder, the environmental stressors can sort of bring it out and trigger an episode. But there's no definitive ruling about, what exactly causes bipolar disorder, but it does seem to have a strong genetic link.
Great. Thank you so much for all that information. We've had a short time. We don't have any more time to continue having this very complex diagnosis and talking more about it. But thank you so much for being with us, and everyone, thank you so much for staying with us this long. And I think we're going to Tanya now. Thank you so much, Michael.
Thank you.
Hello, everyone. Thank you for staying with us for these 2.5 hours. It's been a pleasure to have presented this information to everybody. I wanted to also thank our presenters, Alejandra Trujillo, Daisy Rosales, and Michael Mikulski, our moderator, Sarah Pineda, to our sponsors, the Los Angeles County Department of Mental Health, the Los Angeles County Department of Children and Family Services, the Substance Abuse and Mental Health Service Administration, known as SAMHSA, Whole Foods, and to the California Community Center for their generosity and support. We thank you all. Also, we truly appreciate the support of Senator Alex Padilla, Assemblywoman Luz Rivas, and actor Jacob Vargas for sharing their support and their touching messages for the mental health community. A special thank you goes out to our El Centro de Amistad's Community Relations Coordinator, Flaviola Garcia, and Margaret Brown and Beth Hernandez-Casey at socializela.com for putting this wonderful conference together. It was truly a labor of love. And finally, we are extremely grateful to our wonderful staff for providing excellent services to the families and individuals we serve in an effort to reduce mental health barriers, improve the quality of their lives, and to make their days more hopeful. To find out more about El Centro de Amistad, please go to our website at www.ecda.org. And myself and the staff at El Centro de Amistad really thanks you for attending this virtual conference. Thank you.